morning. I will be talking about pathophysiology of angle closure, old and new concepts. I have no financial disclosures to make. So what we all think is angle closure tends to happen in an anatomically small and a crowded eye, and pupillary block is one of the main common mechanisms of angle closure. Now it's interesting to think how an angle closure a pupillary block must be taking place. So once you have an aqueous that is formed here at the ciliary process, it moves over the lens capsule in a form of a donut before it leaves the anterior chamber via different pathways. But at times when there is opposition between the iris and the lens capsule, you may have resistance to the aqueous flow and increased pressure behind the iris that leads to iris bowing in this pattern. This gives a typical Bombay appearance. A sail is a perfect example of how an iris must be behaving under pressure. Other mechanisms are the non-pupillary block mechanisms. The first is the Plateau Iris configuration, where the peripheral iris rises up from its root in opposition or in close proximity to the angle wall and then turns sharply away from the angle towards the visual axis. And the central anterior chamber here is relatively deep, but the periphery is shallow. Another mechanism is the thick peripheral iris roll. The name itself suggests that the iris volume is more here, and the iris is thrown into different circumferential folds which occupies the major portion of the angle, leading to blockage of the angle. Another mechanism is the exaggerated lens vault. So quantitative analysis suggests that majority of the eyes have more than one mechanism that plays a role in angle closure. One may have some may have one of the predominant factors and others play the contributing role. So why all narrow angles don't develop acute attacks? If you actually see, of all the angle closures, only 20 to 30% of them would land up with acute angle closures. The reason behind this is that it's not only about the static anatomy, but dynamic features of the eye play a major role in angle closure glaucoma. Now, the fact that Chinese people have, say, more than 5 times more angle closure than Europeans, yet there's a beautiful study done by Congdon et al. Which showed that in their population-based study, that there was no greater proportion of small eyes or smaller mean anterior chamber depth when compared to European or the African population. The graph here shows the anterior chamber depth in the 3 ethnicities. So we actually need to look beyond anatomy. So what is that beyond anatomy? The first is the behavior of the iris. Now iris is like a sponge. Normally the iris may freely gain or lose extracellular water and loses volume after physiological or pharmacological pupil dilatation. But the iris of an angle closure eye is more water retentive. It has a poor fluid conductivity and it actually retains more water when it gets dilated, and it gains volume. So if you see this graph over here, the A and the B group are the angle closure eyes, whereas C and D are the open angle eyes. This graph is showing the response to dilatation, that is 1% tropicamide and 10% phenylephrine. And if you see, you don't actually see this kind of phenomena in normals. The response over here is actually poles apart. So in A and B group, there is gain in iris volume, whereas in the C and D group, the iris volume is lost. Another mechanism is the choroidal expansion, and that could be one of the important factors. Now the eye receives its ocular rigidity because of the cornea and the sclera, and choroid occupies a major portion. It has a very high blood supply because obviously it has to give nutrition to the eye. Any hemodynamic flow disturbance here can lead to exponential rise in intraocular pressure. So the input and output fluid, including aqueous and blood, have to be dynamically balanced in order to maintain IOP in the normal range. So such delicate balance can be disturbed by pathological changes in the iris and choroid as pathogenic factors of angle closure glaucoma. So one of the possible sequence of angle closure could be that the choroid expands and the IOP rises acutely, the aqueous leaves anteriorly, the anterior chamber volume decreases, because of which the lens moves forward and there is increase in pupillary block. The iris therefore moves forward because the pressure behind increases and the angle closes. Now the tendency for having positive pressure during a cataract surgery, especially in the era of large incision cataract surgery or an extracapsular extraction in eyes of angle closure with patent iridotomy, was around 20%. So probably not only intravascular expansion but extravascular expansion probably supports the theory that there must be some choroidal expansion taking place. 15% of angle closure glaucoma demonstrated uveal effusion on UBM. This was shown by a study done by Kumar et al. Another beautiful study done by Sakai et al. From Japan showed that uveal effusion was not only seen in acute angle closure eyes, but also in unaffected fellow eyes and chronic angle closure eyes. This does not generally happen in normals. Choroidal thickness is more in angle closure eyes as compared to normals and open angle eyes. Just touching upon the genetics, that the heritability of narrow angle is reported as high as 60%, and siblings tend to have 7 times more narrow angles than the general population. Yet we fail to put PACG into any inheritance pattern. Molecular mechanisms leading to angle closure glaucoma are poorly understood. The contribution of 2 single nucleotide polymorphisms in PLACA and COL11A1 were confirmed in large angle closure glaucoma cohort in China, Australia and Nepal. Future functional studies are required to validate the role of them in the pathogenesis. The disease is also influenced by mood, weather, living habits and other environmental factors, which suggest that it is genetically complex disease. So to summarize, most persons with angle closure do not suffer acute attack, probably because of the dynamic nature of the iris. Angle closure glaucoma is more common in Asians, but not because they generally have smaller eyes. The intraocular pressure can be higher behind the iris than in anterior chamber. There are physiological risk factors for angle closure glaucoma that add to the anatomical risk factors. I think that stopped. I'll just continue till that time. Yeah. So the UBM and anterior segment OCT angle measurement should actually take account of the pupil size at the time of imaging, because with every 1 mm increase in the pupil diameter, there is change in the iris volume. And lastly, we know that choroidal expansion is a contributing physiological feature of angle closure. Now there are many questions that remain unanswered, So there are many questions that remain unanswered. We don't know why some people with narrow angles develop PAS while others don't. And we don't know which narrow angle patients that enter a clinic would have an attack and when. And how does a psychological status of a patient would affect the disease. So I think that angle closure glaucoma is partly a systemic disease, and we need to look beyond eyeballs to understand it better so that we can treat our patients better. Thank you.